What can go wrong during sex? I was suggesting that woman is on top.
Oh my goodness.
So you're telling me if I took finasteride, it potentially could have shrunk my penis?
So you've held all our testes here in the same bowl.
I could have jizzed on stage.
My name is Suhail Essa.
Dr. Ntlanta
Dr.
Vilagazi.
Vishen Naidu.
Dr. Brendan Matthews.
Dr. Naseem Sharif.
And this is the
Gentlemen
Gentlemen
Clinic
Clinic
podcast.
Let's rock and roll, boys.
Welcome to another episode of the Gents Clinic podcast. 6 South African male medical doctors on a mission to change the way in which we perceive men's health. I'm going to let everyone here at the table introduce themselves.
I'm Dr. Naseem Sharif.
Dr. Brendan Matthews.
Dr. Vishen Naidu.
Dr. Ntlix Vilagazi.
Well, Ntlanta.
Switching it up today.
Yeah. And I'm Dr. Suhail Essa. And this is the Gents Clinic podcast. All right, guys. So, as always, we are going to start with interesting cases for the week. Anyone have anything? Brendan, you were telling us you had something.
Yeah.
You had an interesting case for us.
Yeah, man. And I hope that this actually becomes a topic for today because it's something that hit me quite deep, you know, when I saw this patient. So basically, bodybuilder. Right.
Oh, wow, okay.
Yeah. So looking at the two of you,
Is it the same person you when we were at med school? We had a
no,
brief discussion about.
it's totally someone different. It seems like you always want to talk about this guy, Vish, but no. Let's leave it. So basically, he's a bodybuilder, you know, and I didn't actually have to ask him if he was a bodybuilder. I could see that.
But was he a professional?
No.
Okay.
Well, I didn't get into that, but no, we don't. You guys.
Because the majority of guys, okay, but continue.
So basically, you know, I walked into the workplace and I saw a guy waiting for me. And the first thing that struck me was the size of his arms. But they were so artificial, you know. They were just like thin forearm, like mine, thin like mine, and massive bicep, and massive tricep.
So did he just train arms?
No, I'm sure you know.
Yeah, no, I mean, I'm just thinking of, you know, these people that are always trending on social media.
Yeah, you
This
see
guy
those-
who's always
You
with
know,
these
it's
big arms that are
artificially
not
mass
proportional.
but he's like was even massive shoulders, massive lats, massive calves, but the rest of his body was like a twig. So you can just have that picture in your mind.
Yeah.
So anyway, he looked sick though, you know. He looked sick as he came into the practice. And when I actually sat down with him, his main complaint was that he's got like these growths, you know, on his bum and in another spot on his arm, and they're painful. But, you know, to make a long story short, basically, he was using steroids, juice, you know. He was using steroids,
Anabolic steroids.
for 3 years. He had been using them for 3 years, non-stop.
Wow.
Sure.
So specifically, I was using testosterone at very high doses, so like 1 gram. I'm sure we'll get into like different doses that he was using, but that just sounded high to me. I don't know in the bodybuilding world, is that a high dose as well?
We have no idea what people are taking out there. We have no idea.
Okay.
Also, you don't even know what
What
stuff
type
he's
of test.
taking, and
Yeah.
you know.
So he was very open about it because, you know, I asked him within the consultation, I asked him like, so what do you think has caused your problems? And he was like, no, I think it's my steroid use, you know. And when someone gives you what they think could have caused it, it helps you work together with them
Yeah.
to get to the bottom of it. And he was open with me and told me use like Deca, which is nandrolone, and test very high doses for 3 years non-stop.
Of which type of testosterone was he using?
I'm not sure, but injectables. He was injecting. So after 3-year period, he had like a change in his life, a big life event, and he then stopped gymming, and he stopped the testosterone. But I came to find out later the reason why his arms were so big and his shoulders, because he was injecting oil into his muscles as well.
Sure.
So he told me he was using Synthol. So I'd never heard of Synthol before. I checked it obviously after I consulted, and it's like a oil that bodybuilders inject into.
Yeah, I've seen those videos on those people
Yeah.
trending on like TikTok.
I don't think it's
Brazil.
like a
It's
filler.
massive. It seems like every.
But is it common in bodybuilders? That's,
You were
I don't
supposed to
think it
tell
is.
us.
You were supposed to tell us in the world.
No,
that
it's
You don't
not.
see it.
It's, I mean, it's not a common. It's
Is
not
it
a
is it
common
like
thing.
a
in
muscle
like
belly filler?
professional, in professional
so, yeah.
bodybuilding, I don't
No,
think it's as common.
even in junior. I mean, people who take that kind of stuff, I'm sure, they just chance takers and.
Yeah,
they're being
because there's no
misinformed.
strength.
I
It
mean,
doesn't
you-
help you. It's just for the look, you know.
And the look is also disproportional.
Yes.
know,
Is it more just like I mean, the assumption is that, you have rounder muscle bellies or, where you may have a short muscle belly.
But I
you
guess
inject the stuff.
It will actually look nice if it's done by a professional, I think. But these guys are just doing it, and
Yeah.
his muscles look funny, man. So even though he's really sick, this guy, he's really sick and he looks really sick and he's wasted. Like his muscles are small, but those parts are big. And so come to find that he has all the symptoms of low testosterone.
Which are?
Yeah, with all these muscles.
Yeah.
Oh, muscles.
No, not real muscles, you know. So basically he says that the first thing he said to me, Doc, I haven't even wished to have a woman in the past 4 years. Like I don't even.
What?
Because obviously I asked him about his HIV status, you know, and I asked when last he was with the woman, and he like giggled. He's like, I haven't been with a woman for 4 years. And I'm like, why is
Jeez.
that? And he's like, I just don't even wish.
And when did he stop taking the
4
test?
years ago.
Oh, wow.
Yeah.
Sure.
He doesn't even wish. So his libido is non-existent.
Yeah.
He has erectile dysfunction, which was a given. I didn't even have to ask him, but I still asked him. He's depressed. He feels like just low energy all
Yeah,
the time.
yeah.
You know, he always sleeps. He feels hopeless. You know, tired. His muscles have shrunk. His balls have shrunk. That's obviously as a consequence of the long-term use of testosterone.
Yeah.
So he has small balls. He has some gynecomastia as well.
Yeah.
He was injecting Synthol into his pecs as well, but
What?
he also has gynecomastia there too. And I just felt so sorry for him, man, because he says, you know, the thing that made me so upset or like feel like I don't know what our health system is up to, you know, private and public.
Yeah.
He says he's been to a hospital 3 times before he came to see me. And they always just, you know, giving him pain medication because he says he has pain in those areas that I told you about.
Yeah.
They give him pain medication, check blood for his kidneys. They tell him come back. Then he goes to somewhere else. No one talks to him. No one even asks him like, why your arms are so big.
Yeah,
You know,
yeah,
they just
yeah.
look at him and judge him with a stigma, have stigma against him. And so I felt like I really need to help this guy because he can really benefit. I believe after blood work and stuff
Yeah,
from testosterone replacement therapy.
And it's painful to see those patients, like people who come to looking for help, and they even tell you straight, I think it's my low testosterone. And they'll still, the doctor or whatever, will do everything else except give you a TRT.
Yeah, man.
They'll send you psychology, they'll do blood tests, and no
But
help.
I mean, what would be what's your management plan for this patient?
Okay, so first I need to see where are we standing? Where is he standing?
Yeah,
You know,
yeah.
what's going on in his body. The lumps that he has are areas of synthol that have collected in an abnormal way. So these will need to be removed, you know. Those are what's causing his pain. But in terms of all his other symptoms, I need to find out how is his liver function, how is
Yeah.
his cholesterol, how is his
Wait,
blood
just to
pressures,
take you back a little bit.
mm.
So, what did this guy present to you? Because it's
pain.
so
in
he
the
just had
arm
these pains.
and the pain
Yeah,
there,
yeah,
which I
yeah.
found out were from those lumps that was caused by the synthol
Mm.
and chronic injection at those lumps. So sort of like
Yeah.
hematomas or
So
organized
like blood-
abscesses. Yeah, I'm not
for
sure.
the people that are watching. this
Yeah.
blood-
Yeah,
Does he have kids? That's
No, he
curious.
doesn't have kids. He lives alone. Apparently, he had a lot of women back in the day
Yeah,
when he was in
yeah,
his
yeah.
heyday.
In his
But
heyday,
yeah. So basically, I need to find out where are we at. You know, all his organ functions. I need to check. You know, the hormones that are produced in his
Yeah.
brain, are they still functioning? And then find out what's the best we can do for him. And what Nas was saying, like you go to your doctor and say, Doc, I think my testosterone is low. Your doctor will probably do every other test under the sun and do your testosterone, but still not consider testosterone replacement therapy.
Yeah. Well, I guess I've worked in a primary healthcare setting, and majority of the time that's where we'll see these guys come, and just to defend, our decision. I mean, if you know our public healthcare system, you know how overworked we are. We know, and even cost cutting is. I mean, it's a huge thing. You can't just order, free tests and testosterone level in every single patient. And it generally, like you're saying, there's quite a lot of psychosocial issues that are also involved, which means you need to spend more time with the patient. You need to, dig deep into the issues, which is something we don't.
And then I suppose,
we don't
the
have.
other aspect of it is because we have a failing public health system, a lot of people, obviously, if they have the means, they will try and seek out help from private.
Yeah.
But with, currently how our health, even our private healthcare system is set up, yes, you could potentially go directly to an endocrinologist. But then would you know you needed an endocrinologist? No. So you'd need to start off at a general practitioner.
At a local clinic,
How many general practitioners are going to look at a man like that and say, yeah, I think you should see an endocrinologist? Or would they just rather say, I can treat his pain, I can treat the symptoms he's presenting with, but not really, let's not get down to the root cause. Yeah. So this guy could end up spending like months on end, not getting the appropriate care that he needs. Or, there's an online platform I know about. This one. Where you can actually get.
I want to counter what you said, right?
Yeah.
About how we've got long queues and whatever. This man he's hypogonad. He's got hypogonadism. His own testosterone is buggered, right? Because of his long-term use. Look at everything he's going through, and so many men out there are going through. They can't perform how they used to, whether it's sexually or physically. Energy is down, cortisol is up. They just feel like they are not a man anymore. You understand? And what does that lead to? Depression, like he has, suicide. Suicide thoughts and so forth. So what makes someone who you're gonna sit for 30 minutes and talk about their diabetes better than a man who comes with a serious problem of hypogonadism? Why is it that a man who comes with problems of manliness gets pushed aside? Why is that?
No, I think the problem is not just testosterone or man-related issues. The problem is, all around. Whatever condition you come with, we tend to just try and. I mean, if I even know what problem you have, I just make sure I cover that little bit I have. Just check, is your sugar well controlled today, and if it is, I don't bother to ask how did you even get it so well controlled, because patients also know the tricks of the system. Patients will starve themselves a day and more so that the HTTs in the morning are low. And if you're not digging deep, you're not doing bloods and following up the HbA1c, it's easy for you to just repeat the script and send the patient away. But I think what I was trying to say is that, it's less time for the doctor, and because of the problems that we have. But you touched on something that's very important about the fact that you obviously concluded that this guy is hypogonad because he's been using testosterone for a long time and probably didn't worry about any post testosterone therapy to bring back his natural testosterone production. What are the functions?
Good conversation to have. I think we can probably base a lot of this episode around testosterone and testosterone replacement therapy, and also we can also touch on, because specifically in this guy, he was using exogenous testosterone, getting testosterone and putting it into his body. So what effect that has on the body?
Yeah.
Using it, incorrectly at high doses.
But do they know that? Does everyone who's using it know? Because I asked him, so do you know what testosterone actually does to the body? And he didn't know.
So I think it's important for us first to talk about what does testosterone do to the body?
Yeah.
What is actually its actual function?
Yeah.
Then we can talk a little bit about, the incorrect method of using testosterone.
Yeah.
And then we'll talk to you about the right way.
Yeah, that's
and
good.
who actually should have TRT.
I think also, since we know that there are people out there using it incorrectly or abusing it, as what we can say, and perhaps reach out to them as well, to be able to reach out to platforms like us and look for help before things actually go.
Yeah.
Okay, wow.
So let's
Yeah,
start.
yeah.
Nas, I think you being the quietest member currently on the table, I want you to tell us a little bit about testosterone and what it does in the body.
Okay,
And give us the history, the studies, the research that's been done on testosterone over time.
Oh, poor Nas.
Nas is the genius at the table. So
history. Okay, look. So, a human body, is heavily influenced by hormones, right?
Mm-hmm.
You can imagine like you can imagine building like a brick wall or something, right? Like a building, and you can build it; it'll stay as it is for a long time, right? But a body, a living organism is different. It's under an influence of, it needs to be constantly told what it needs to be doing, right? So hormones are there to tell the body what to do constantly. I can give you an estrogen hormone, right? And all of a sudden you start to develop breasts, you start to develop these different kind of things. And if you can give a woman testosterone, and she can start to develop hair, she can start to develop an enlarged clitoris, these kind of different kind of things, right? So your body needs to be constantly told what kind of things it needs to, what it needs to be doing, right? So testosterone is like the male hormone, right? So it gives you a lot of sexual desire. It gives you muscle mass. It helps you with like your mood. A lot of it with your mood, right?
Yeah.
So if you have a deficiency in testosterone, which happens to us inevitably as you get older, you start to reduce those.
yeah, what do the studies show on that?
I mean, I mentioned this so many times.
I know you love it, so I want you to say it again.
Many times.
So you said there's libido, obviously
Libido,
sexual
yeah.
desire.
Ting! We'll have an image pop up here. Nas, you want to go through the list again, and then in the edit, he's just going to...
So bone density,
Okay.
you said,
Okay.
right? And you said something else.
Bone density, you said muscle mass,
Yeah.
you
Muscle
said
mass.
mood changes.
Mood, yeah. So
mood changes,
yeah.
libido.
Yeah.
And
And?
fertility.
Can also just development of your
Guys,
secondary
so
sexual characteristics.
Think about, we're all together at varsity, right? A guy at university who's 20 years old can wake up in the morning, or let's not even say wake up. You can study the night before, right? Sleep at 3 a.m.,
Yeah.
wake up at 6 a.m., go and
Yeah.
write your exam.
Yeah.
Get back from your exam, change your clothes, put on your soccer clothes, go and play a soccer match.
Yeah.
Get back from the soccer match, back into res, and shower change, go to a party.
Yeah. Post-exam party. We had those all
Post-exam
the time.
party, that always happened. After
Yeah.
a soccer match, you go to a party. At 2, 3 a.m., you're still fresh. You can still get an erection. You
Yeah.
can still have sex,
Yeah.
right?
Yeah.
You can go at 3 a.m. have
Powers.
sex. Wake up in the morning.
Was this your routine?
He's telling us about his own routine.
Yeah, you know, all of us used
Used to do that.
Hey, I was in bed by 10.
Guys, listen. You're like,
But we get your point. We get
yes.
your point.
And you wake up in the morning and go to the dining hall, have breakfast with everyone, and debrief about how your day
So
was.
so just so that the viewers at home understand, because now a lot of the people online and on social media, they're getting to know us a bit better, and a few people have actually asked how we know each other. So just so that you guys all know, we all basically lived together at Reyes, and we studied at the University of Wits. And so that's why this topic, this interesting story, may be relatable for those of you who've gone through the similar experience.
Now you tell me someone at the age of 35, 40, 45
Yeah.
can still do that. Because literally you could sleep that morning after breakfast and wake up midday and repeat what you done the previous day. And that is all probably testosterone.
Do you think that it's all testosterone related though?
Or
I
just
also feel
age-related
like
issues?
I also feel like now my knees click when I stand up. There's other things that
No,
have
but I
also
think
changed.
testosterone is a
related
large-
to testosterone.
But yeah, age is
Yes.
definitely.
And testosterone is a large impact of the description that I just gave. Is that not so?
Now, Nas, then a question to follow on what he said. Do you think if somebody who had low test, or naturally low test, as you age, I start TRT, do you think I'll be able to sleep at 3, wake up at...
You will be surprised, yes, 100%.
You think so?
I think so.
Okay.
Yeah. So let's start there. What is TRT?
No. We still have. We've spoken about what is testosterone,
Yeah.
and we know now, obviously, what testosterone does. But let's talk a little bit about like the common symptoms that someone would come to us and tell us, "Hey, I've got this problem. I've got that problem."
Okay, we mentioned this in the first episode, right? So, but it starts with vague symptoms and there's more serious ones.
Okay.
So you're starting to maybe feel tired, brain fog. There's like constant fatigue, right? Muscle mass is decreasing, and then also
Even with external stimulus, like you're going to the gym or you're doing something, and
even
you're
with
losing muscle.
yes.
Okay.
and then also it starts to become a real serious problem once you start to have erectile dysfunction. That's when most people start to come and say, "I have an issue." Right? Yeah,
Or low libido.
and low libido.
Okay.
So those are the symptoms of low testosterone.
So that's how. So anyone that's obviously don't wait until you've got no erection to come come and consult for this problem. I think is probably the takeaway point. But it can be as subtle as mood changes, huh?
Yeah.
Like just feeling low mood, depressed, don't know why.
So, like, I've read about this. The fact that exercise, increase, especially, weight training, increases testosterone production, which is why I find that after an exercise, I'm so, I'm ready. I mean, if you guys saw this morning, I train in the morning and I'm just ready to tackle the day. And when I read that kind of, studies or information, I could relate to it, So I mean, I can attest that, with exercise, you're definitely going to increase the amount of testosterone you're producing. But
have you had periods where you were like, okay, maybe you took a week off, for example, and you felt like, oh, I'm feeling like I've got less energy. I don't have, I'm not sleeping well. Because even sleep, they say testosterone, if you have low test, your sleep, you can have sleep disturbance.
Yeah, no, I've never experienced that. So I guess I've just for now, because we're still a bit young, so you have the the time to train and do all these things. But I'm sure with time I might reach that.
Obviously, we can't see what's going on in the body unless we're drawing blood from you every hour.
Yeah,
But I think that when you in your early 30s, you feel okay. You're still young, you live a healthy lifestyle. But when you go to the gym in the morning and you come out feeling that high that you do, maybe your testosterone is peaking to what you were.
So I
when
think
you were
there's
18
a lot of hormones that get released, after a session. I don't think it's just testosterone. There's also endorphins. You feel good.
Adrenaline.
I was listening. There's another podcast I listened to called the Huberman Lab. He's a neuroscientist. And he does a lot of interesting studies on dopamine and those types of things. And he said that one of, in life, you got to go through difficulty to actually feel naturally happy. So things like the way you can stimulate that is like exercise is one. You're putting a stress on the body, and through that stress, when you come out of that stress, your body naturally releases dopamine. Like, oh, well done, you got through that.
Yeah.
If you go through like a cold plunge, you're going into an ice bath or even a cold shower, that causes your body to be like in a stress mode. And once you've come out of that stress mode, your body's like, oh, we got through that. Let me give you some happy hormone. And so I think that exercise has many benefits. One of them is definitely
I can study med school for 6 years over again just to walk in the Great Hall and get that graduation certificate. That was like testosterone, dopamine, adrenaline.
Everything released at the same time.
That was everything released at the same time. I could have cheersed on stage. That was the best. But anyway.
So how true is it? How true is it that with low testosterone, cognitive function is also affected?
And even Huberman also mentioned that testosterone is a hormone that makes effort feel good. So if you have more testosterone, you'll be happier doing those hard, difficult things.
I see.
Yeah. And I also think that exercise is like I think it's like a meme or something. People always say the first antidepressant you should take is go to the gym. If you're a man and if you feel low mood, just go to the gym.
Let's go to the gym. Exactly.
Exactly.
Yeah, no, I definitely think that it does have a mental effect apart from just the physical. You definitely have some mental effect.
Those are the signs of low testosterone.
Yeah.
Testosterone.
But you had touched on it, you had mentioned when Klantla was talking about testosterone and, when he gyms in the morning and this and that. Now, in terms of diagnosis, how do we diagnose low testosterone? Obviously, you can take blood tests, but I think maybe Vish, you can talk a little bit about
Yes,
the peaks, the troughs. How does testosterone cycle during the day? Like, and at what point, when should we test? When should we not test? What's the optimal time for if I think I have low test and you send me for blood test, when should I go and get tested?
Okay, so again with low testosterone, so as Nassim mentioned about clinical signs and symptoms. So again, we categorize them obviously clinically, mood disturbances, all of those type of things. So say you have now a high suspicion of testosterone deficiency. So you ideally want to do some blood work. Okay, and then, to diagnose basically hypogonadism, there's two different types. Okay, so you can have primary hypogonadism or secondary hypogonadism. Okay, we'll discuss that a bit later as well. So basically, when you want to obviously do your blood work, you're going to do your testosterone, you're going to do a sex hormone binding globulin. So basically, looking for your free testosterone, and if too much of testosterone is bound in the body, as well as your albumin, your normal CMP, like kidney function. But you're also going to do your luteinizing hormone and follicle stimulating hormone as well. Okay, so apart from that as well, we'll also talk about diabetes and basically other medical conditions that's aiding in hypogonadism. So you also do your HbA1c, your lipid profile. Okay, so basically
for
cholesterol, yeah.
These can all contribute to vascular problems. Yeah.
So essentially, diagnosing on blood work. So if you have, your main thing you're going to be looking for is your testosterone level. So ideally, there's a certain time in the day which you want to check your testosterone level. So cyclically, normally your testosterone is higher in the morning and lower at night. Okay, so you'd encourage the person to get their blood work tested in the morning up till around 11 a.m. Anything afterwards, you'd advise them rather to just get it tested the next day.
If they happen to test maybe let's say later in the day, and you want to track their levels, would you suggest, okay, on the next time you're also going to test at that time? So let's say 12 to 1 o'clock they decide to go and test. Now you're like, okay, let's do some intervention, and then next time you test, you're going to also test at that time?
So the thing is, I think, look, you don't get an accurate representation because you also have different pulsatilities throughout the day of your testosterone release. So I would suggest, they get tested during the right times. So you see what, their basically the higher level would be, the peak and the troughs rather. So first you'd obviously look at your testosterone level, if it's low. So obviously with age, there's different levels of what's considered low. Okay, and then I think we'll go through that a bit later. We just obviously we'll check those values.
Okay, guys, I know this is a bit of a sidetrack.
Yeah.
But I've been asked multiple times. So I'll see someone, and this patient will say to me, "Doc, I think I need TRT." And I ask, "Okay, why? What's the problem?" And they say, back in, like Brie was saying, when I was 21, I used to go 5 rounds. Now I only go 3 rounds. Do you think, testosterone levels actually play a role in that? Or expectations?
I definitely.
People don't know how long sex is supposed to be, man. How many?
But when these guys come, when people speak to you, do they come to you and go like, "Yeah, I think my testosterone level is low," or do they just go?
No, they say no. That's how the discussion normally starts. I think there's a problem with my testosterone levels.
Look, now we've gone through diagnosis.
Yes.
Now, so most people now kind of get the idea of, okay, if you've got these list of symptoms, you come to us. We'll generally, do these tests. We'll give you advice and do these tests. But now I think it's important for people to understand what actually can we do about low testosterone. And the question then comes in, testosterone replacement therapy. What is that, Nas?
Okay, so Vish was mentioning those are different blood tests, right? So there's GnRH, which is a hormone that's secreted by the hypothalamus, which goes to the pituitary gland. which produces LH and FSH, which go to the testes, tell the testes to produce sperm and to produce testosterone, right? Over
And
time,
I think
as
it's
you get
important
older,
for people to understand. We'll probably put up a graphic there so people can understand there's that pathway for testosterone.
yeah, and then those blood tests will tell us where the problem is. Testosterone goes back and inhibits those ones that secrete those hormones.
Yeah, so basic explanation, testosterone tells the brain, hey, stop making.
There's enough.
So
There's
if
enough.
you have a high testosterone level, so for example, if you're injecting or taking exogenous testosterone,
Yeah.
Yeah.
Yes.
your body is going to tell the brain
Juicing.
stop producing testosterone. So basically, that signal or that impulse that goes to the brain, basically to stimulate GnRH secretion, is now cut off or it's inhibited.
Exactly.
Because correct me if I'm wrong, but the idea with the cycling, the reason why we have high in the morning and low in the night is because when it dips in the evening, you stimulate GnRH because the test levels are low, you stimulate it for the next morning so that it creates the release. Or am I getting it wrong here?
Yeah. So
No, is that not the cycle?
I get what you're saying.
Okay,
I think that diurnal variation is just a cycle the body
Oh,
has.
I thought that
Yeah.
maybe it's
So-
because
so for example,
So what happens? Okay, what tends to happen? Here's the thing, right? So now what happens is that a lot of
Finish that.
people.
Relax.
Yeah.
So what happens? A lot of
Finish.
people is they take exogenous testosterone and it inhibits all those things.
Yeah.
So this is the common people who need TRT are those people who had prolonged testosterone use in their past, and also elderly people who also now have low testosterone, right? And
Just
also tend to
naturally
have,
over
naturally,
Oh, okay.
and also tend to have diabetes and
Yeah.
erectile dysfunction,
Yeah,
right?
yeah.
So those two, an elderly person above the age of 40 who has low testosterone and diabetes, and also someone who has prolonged testosterone use, right? Those people really need testosterone replacement therapy. Where what's happening is that because of that shutdown of all that system, we're giving enough testosterone just to give them those function back again,
Yeah.
right? TRT is different from juicing, right? Juicing is where you give so much testosterone, it's
1
ridiculous.
gram, like Brendan was saying.
1 gram a week, right?
Too much.
And not only that, they also take other stuff like
Yeah.
DHT, all those other things they take on top of it. We're giving just enough that it shouldn't really be. It should be thought of as a replacement for the natural testosterone that existed before, right?
Yeah.
So basically, we're taking your testosterone level from what it is to back what it should
To
be.
normal.
Yeah,
Yeah.
to
Back
normal
to
levels.
normal.
Yeah.
Back to normal.
But again, with that being said, with the pathway you've mentioned, so as we we're mentioning, primary and secondary hypogonadism. So essentially, primary would be the problem is at the testes.
Yeah.
Okay, so either problems like if testicular tumor or infections or certain conditions which may predispose you to having a testicular problem, or like orchitis or mumps orchitis. That's something we see very commonly in the casualty. Okay, so those are just some of the common things.
That will need testosterone.
So that would be diagnosed with a low testosterone but a high LH.
Yeah.
Okay, and because your body is, it's your brain is signaling to the testes that you need to produce testosterone.
Yeah.
So basically, in that one, your balls are not
So
working,
wait.
your testes are not working in that case.
Exactly. Whereas now secondary is now a problem in the at the axis in the brain, basically.
Yeah.
Okay, so then you would have a low testosterone and you may have a low or normal LH level.
So there's different kinds of testosterone replacement therapy.
So just some of like the secondary hypogonadism causes as well are more systemic causes.
So in those cases of primary and secondary hypogonadism, they definitely need TRT.
Yes.
Uh-huh.
We first need to mention lifestyle modification, right? Obviously, we mentioned all those previously. Zinc, right? Vitamin D, exercise, good diet, sleep, all those kind of good lifestyle things, and also those supplements like ashwagandha and tongadali, right? And there were some people who not
We had
understanding
mentioned it
that.
before, but I think this
I think I was
episode
going to
is dedicated to it.
Yeah.
So I think
Yeah.
we should talk specifically on this topic a little
There's
bit
so many
more.
things that can increase testosterone, right? So,
So go through a few of the most popular and most effective methods
what
that you
we
can
use,
naturally.
okay, there's
use
shilajit, which is like molasses. There's Fredosia agrestis.
How do
there's
these things
tongadali.
work? Tell us a bit.
Most of
about
them
how-
increase LH, so that by the pituitary gland to produce more LH, which goes to the testes and produce and stimulate to produce more
And these are all
testosterone.
natural supplements.
Natural
that you-
supplements.
Okay.
I want to go over that, how to actually take the Tongat Ali and ashwagandha, because we
Yeah, I
want to
mean, you
mention
were
it
actually
before.
correcting me. I always thought you just take Tongat Ali, ashwagandha, and ZMA all together, same time, consistently.
Yeah, you have to actually cycle Tongat Ali. You have to take it for 4 weeks and then 2 weeks off, and then repeat again.
And
You
in those
can't
2
just take-
weeks, you should use ashwagandha.
Yes,
And
If
this, I'm guessing this is evidence based, obviously.
yes, evidence
Yeah,
based.
this is-
Maybe we should
Just
share
tell
the
us,
name of the
yeah.
study
Yeah.
as well.
Okay,
Yeah.
where we.
Yeah. No, we'll put it
Put
up.
it somewhere.
Put it up.
Why,
yeah.
why do you cycle between the two?
So you
Tongat
get
Ali and-
you get adaptation. You get like your body gets used to it.
I see.
Right? So it stops working.
Yeah.
So you have to now cycle it so that it can still produce its effect. So what you can do is, if you're getting confused with 4 weeks, 2 weeks, and you don't know which one you are, you can just take 1 month of ashwagandha, 1 month of Tongat Ali, and just keep doing 1 month. Or
And
you
the
can actually do it
ZMA
properly.
consistently.
ZMA every day. Ashwagandha, you don't have to cycle. You can take ashwagandha every day. Right? So you can decide by yourself which one do you want to try and see.
cycle between
Wait, you said ashwagandha you can take every day,
Ashwagandha you can take every day.
but then you said you
Tongat
should.
Ali, you have to
You
cycle.
have to cycle
It's a Tongat Ali.
Also, so you okay? So just so that I understand correctly, with ashwagandha, do you have to, if you're taking it every day, in those 2 week periods, you just stop taking the Tongat Ali, and you can continue maintaining your ashwagandha. Then.
I don't think you should take both at the same time. So if you
So
want
then
to
the
take
more effective method is to actually cycle between
one,
the two.
one at a time.
Yeah.
So
Different type of cycling.
the biggest reason why we offer these approaches, lifestyle, Tongat Ali, ashwagandha, is because perhaps the undesirable effects of TRT.
But I think
Most
this is
common
more
one
also,
being-
this is also over the counter, so you can go to the
Yeah, you can
chemist,
go
you can
to
just
the-
buy it.
What I'm saying is that when you explain TRT to someone and you explain it to them properly, they might say, "No, let me try your other way."
Well, let's
first."
talk about
And
why
that's
people
because-
may not want to go on TRT.
Yes. So the
What's
biggest
reason
one,
why?
the biggest one is that it can cause infertility.
Yeah.
So
Especially in young
basically-
men.
yeah,
What
especially
is like TRT, obviously testosterone
Yeah.
replacement.
So,
Yeah, so
we're replacing
testosterone.
the testosterone by various methods, and we'll talk about the various methods.
So
but the
basically-
biggest side effect, I think, and the biggest concern for a lot of people is the infertility. And
Yeah.
Nas, I think you can tell us a little bit about how that occurs.
Okay, so remember that axis, right? So testosterone, excess, more testosterone will go back to the LH and inhibit LH secretion. And LH is the one that goes to the testes and tells it to produce sperm and
Yes.
also testosterone.
Yeah.
Yeah.
So if you have less LH because of the excess testosterone, you can have less spermatogenesis, and then that's where you get that reduced infertility.
Yeah.
see.
But if you're doing prolonged excess testosterone like juicing, that will shut down the whole system, and your testes start to atrophy, right?
Yeah, yeah.
As long as you don't get testicular atrophy, you should maintain your fertility, right? So that when you stop testosterone replacement therapy, then you can maybe go back and be fertile again.
Yeah.
I
But
see.
if your testes have already shrunk, then
So
there's a
how
big
do people
problem.
know what like fertility is? Like how would you know?
You can do sperm.
Well, obviously, before
Analysis.
you do those
Just
tests, you're not
mention
going to rush to go do those tests.
Yeah.
And before you're gonna
The
do
definition.
the testosterone, you're gonna.
Say
I mean,
definition.
do you want children?
Yeah,
If
yeah.
they
It's a
want to
it's a
have
big
children.
question. So, for example, I had a consultation with someone today, and it was a follow up consultation, and I got his test levels back, and I said to him, before we go down this path of TRT, do you want to have children or not? Obviously, more elderly men over the age of 40, 50s, now they've had enough children in their life, but they are feeling the symptoms. And they're like, I don't care whether I don't have children anymore. It's not going to change my life. I just want to feel better. But for a younger, late mid 30s, maybe early 30s, in some of the
20s,
cases,
I mean, some of
even
these kids
20s,
in their 20s
sometimes.
are taking
They
TRT.
want to still have children. And then the options for TRT obviously become a little bit more limited. We have to try certain things so that we don't block that natural pathway.
Yeah. And I mean, I think we've covered some of the natural ways or the general measures in
Yeah,
order to
yeah.
increase your natural testosterone
Yeah,
production,
yeah.
the exercising,
So yeah, I think
weight loss, etc.
I think it's important that people understand, what are the options for TRT, and what can we offer? Well, what can any doctor offer you?
Okay, most commonly we do injections, right? It's
In history, or you're talking about us?
us.
Like
us.
us.
The most
Like most common is injections.
available and safest studied is injections.
Injections.
Yeah.
Oral? What has anybody done?
So there's a lot of new evidence coming out that oral is safe, but we don't use oral yet. There's also sublingual, which absorbs under your tongue.
There's patches as well.
Yeah, there's patches. There's ones that you can put under your skin. Those people who inject insulin for
Subcutaneous.
diabetes, put subcutaneous. So there's a lot of ways, and they all have their benefits.
Okay, so let's
Their
just
drawbacks.
discuss a bit of the
So the
pros
most
and
common
cons.
one that everyone knows, the injection. The con is that you're going to inject yourself every 2 weeks or every week, depending on what's best for you. Maybe even once a month, but we need to know what's best for you. We like 2 weeks or 1 week. And obviously injection is uncomfortable, but you get used to it. Your doctor can do it for a few times. You can even start doing it yourself, injecting yourself, It's safe. And I think we need to talk a lot about the safety because people are worried out there. Doctors, even medical professionals will tell you, no, it's not safe. I think we must talk about all the safety, but it's safe. It's longer acting than the oral, version. And someone might prefer it because you get one injection and you forget about it for 2 weeks.
It's also the liver toxicity and
Yes.
things like
That you
that. yeah.
avoid.
I mean, if you're taking an oral one, we're worried that you'll get liver masses and liver failure.
Yeah, it's a bit complicated
yeah.
to explain
Yes,
all that,
yes.
but
And kidney
yeah,
problems.
you
But
can
basically,
get kidney problems.
It's safe and we know how to do it properly at the gentleman's clinic. So
Also,
Yeah, but
the
so-
expected levels or the expected outcomes, it's a bit more tricky in terms of oral.
yes.
Whereas-
So injection.
why is that?
So with
Erratic
first pass
absorption, yeah.
metabolism, absorption as well. So there's a lot of factors, I think, also that would need to be considered in terms of oral agents versus injectable
So for the layman,
agents.
so they
Yeah.
understand why.
So injectable has been studied really well and understood, but I mean, there's the new studies about the sublingual and the oral are,
There's even nasal.
and nasal. So they are encouraging, and I think in the future we might go that route because I
Even
wouldn't
creams.
mind if I'm 40 or 45
Yeah.
just putting a tablet under my tongue and getting in my car and driving to work knowing I'm set
With an erection.
I'm set for erections. Wife is happy. I'm set for power in the gym. I'm happy at work. Patients are happy.
Yeah. Less side
With-
effects,
just with
I
a
guess.
tongue, a tablet under my tongue.
Yeah.
So
Guys,
100%.
when the time comes, I'm going to go on TRT 100%.
I am going on TRT when the time comes.
But okay, so just something we mentioned also in the previous podcast, like with taking finasteride as well. So it does block a pathway of testosterone.
Okay.
But does it
DHT.
actually lower your testosterone?
It's a DHT.
So
inhibitor.
just mention the what.
So it's a 5-alpha reductase inhibitor, right? So 5-alpha reductase converts the testosterone to DHT, and DHT is like, you can think about it as the masculinizing hormone, right? It produces beard growth and hair loss, right? And also the increases your penis size actually as well.
So we're just gonna
Sure. So now take
Let's be sipping on DHT.
So now we got
It's a big one, DHT.
THT.
Yeah. But now what happens when you...
Whoa!
Can I
Hold
just
on.
ask you?
DHT causes increase in beard growth,
Yeah.
hair loss,
Yes.
and penis size length.
Yes.
So you're telling me if I took
Even
finasteride, it potentially could have shrunk my penis?
No,
So-
grown it.
shrunk because
It was shrunk.
Shrunk because
you're
it's
blocking,
Less
you're blocking your
DHT.
DHT.
you're blocking the DHT.
Shrunk. Okay,
Sure.
no, I don't know.
No, so I guess there's probably a time for all of this. I mean, your penis is not growing your entire life.
Yeah.
Yeah.
So I mean, if you were taking it...
Like all this
Yeah.
usually happens at puberty.
I guess
Yeah,
if you give
yeah.
a
Yeah, of
15-year-old
course,
boy
of course.
finasteride, his penis won't grow to its full glory that it would have. if
True.
you didn't.
But again, your estrogen levels may also be higher because your free testosterone or your less strong testosterone, so your DHT is your strongest form of testosterone, is being inhibited. And I'm sure like your finasteride for hair loss 1 milligram is not totally blocking DHT, which is why they do mention some of the side effects. And you may I guess end up with slightly higher estrogen.
So I mean, potentially, if you're taking a 5-alpha reductase inhibitor, would you experience some of the symptoms that people with low test?
Yes,
experience?
definitely.
Low libido
Yeah.
is a side effect of
And gynecomastia.
gynecomastia.
Yeah, mood.
Yeah. Even see like
disturbances as
Anavar is DHT, and like women who take Anavar have a larger clitoris.
What?
Yeah,
Sure.
that is a thing that happens.
Wow,
Shit.
Crazy.
Anava. What is that?
It's DHT.
THT,
Oh,
but it's
yeah,
often
yeah.
used, and I think it's. I
As
think
a
we
performance
to
enhancing
push the
drug.
conversation a bit further about the methods of administration and incorrect methods and how people can
Yeah.
end up with.
Yeah.
Let's talk about juice, man. Let's talk about
Juice or
the juice. That's the,
replacement?
no, we'll talk about juice
I think-
first because
I
that's
think
what's interesting.
before-
That's I'm
before
sure a lot of
Yeah.
men have. If you're a man, chances are the likelihood that you've been in a gym around people who are taking their own versions of testosterone,
Yeah.
not replacement, testosterone enhancement therapy, let's call it that, and have misconceptions about it, have had bad experiences. Some may have good experiences, but I think it's important for us to distinguish between what that is and what normal
TRT is.
TRT is that is offered. And there is a bit of an overlap. Like you were talking about the injectable. The one that we commonly use is testosterone cypionate, correct? But the dosing.
That's actually the one that you get in South African pharmacies. So that's
What other
the one that's
common ones do we
approved.
get in South Africa?
There actually aren't any. So any of the stuff that Dr. Matthews was speaking about earlier is all things that people are getting, God knows from where.
But we have access to proper testosterone in other forms, right? Yeah,
Oh,
Yeah.
where?
No, we do at at our pharmacy.
Compounding.
Compounding.
Oh, yes.
Yeah.
We're busy with that. But
Yeah.
I think, what's important is to make the distinguish between the two. So, with Anava, and you were mentioning Anava.
Like we said, I think we can't really discuss some of those things because it's not like you can get them anywhere or.
No, I mean, look, legally we
yeah.
can't get them anywhere,
Yeah,
but
so-
people are getting them
Guys,
illegally.
My thing is that people are using them.
People are using
People
them.
get them illegally.
We need to
know
talk
that.
about
Yes.
The same way
People are gonna use
people
them
use
if they want to
cocaine,
use
people
them.
use heroin, people use nyaupe.
They're
Now
gonna
we
use
want
them. You're
to.
going to use it if you want
Now
to
you
use
want
it.
to hide away when
No,
you're
no, no,
saying
no.
people use juice. People use juice. They use
Yeah.
cocaine.
No, we're not saying. No, we're not saying.
It's like saying, don't
People
do.
use them both together.
That's also true.
And rats also use them.
And end up with priapism.
The reason why I was saying
Wait,
not
imagine
to
so.
discuss is firstly, if these things are not gotten over the counter, do we even know if it's just Anava? Do we even know what these
Do we know
people are
it's
taking?
that's your point?
It's
Okay.
it
Yeah,
becomes
stuff,
it becomes a tough one. But I think what matters is us discussing
So
how we can address problems and
From
yes,
that,
we
yeah.
also covering what
I mean,
we
what do you do?
we are saying
what
is-
do you do? I spoke to an endocrinologist in Cape Town when I was at a conference. Said bodybuilder came to him, said, "Doc, this is what I've been using for the past 5 years. I can't make my wife pregnant now for the past year. Assist me." There was nothing unethical about that doctor helping the patient
Yeah.
to fall pregnant. And then the doctor even said to him, "Listen now, your wife is now pregnant. Let's move in this way. Reduce the dose of this thing you're using, reduce the dose of this, use this one at this dose," and basically put him on TRT. So there's nothing wrong with us helping.
There's nothing wrong with exogenous testosterone.
Yes.
The problem is obviously the illegal things that no one knows what is
Yes,
inside
yes.
them,
Yeah.
and the dosing problem, like we said.
Yeah.
But
No.
here's a more ethical question, right? So obviously, most people use it, and over the counter. Sorry, not over the counter, but my point is like most people use it not for any form of sports competition. They don't use it for bodybuilding. They don't use it because they're a professional soccer player, rugby player, whatever.
Same like my patient just used it for his own
Yeah.
aesthetics.
For own
Just to look
enhancement.
nice.
Yeah.
So it's not like the ethical question then comes in is like, what are you aiding? What are what are you aiding and abetting here? Are you aiding a guy who just wants to look better in life? What should we as healthcare professionals do? Should we say, hey, listen, I don't think it's a good idea if you're just doing this to look good?
For TRT or for
No, not for TRT, because TRT, in order for us to give you TRT, your levels have to be low. It's unethical for me to prescribe you testosterone if I know that.
If your levels are not low.
If you've got a normal level but you're depressed, am I going to give you TRT? No.
But now here's
If you've got bone
here's-
pains, for example, and your testosterone are normal, am I going to give you TRT? Am I going to
There
even
actually-
offer you TRT?
There actually are studies that show that. Don't forget when they say normal or that normal range.
Yeah.
That's normal for obviously that study population, and most of these TRT studies are actually quite low on small numbers of patients.
Of course.
So you might find someone sitting on 500, whatever measuring-
Nanomoles, I think it's nanomoles. per
Nanomoles
liter.
per deciliter.
Is it nanograms per deciliter?
Whatever it is, yeah.
Yeah,
Yeah.
mg. So sitting on 500, but having concentration problems, memory issues, muscle loss, depressed, low testosterone, low libido.
It's fine.
And when you shoot him to 800. So basically what I'm trying to say is that I think there shouldn't be, yes, that's a guideline that we obviously use because there's protocols that support this. But I mean, everything needs to be individualized. I mean, if someone is coming to you like Brandon's patient, telling you, Doc, I'm struggling to have kids, I'm doing it, and you do the bloods and you find that he's sitting on 550, what do you do? Do you then say, ethically, I'm not allowed to now
I agree
to
with-
treat
I agree
you?
with you.
Yeah.
So I think it's just a
True.
guide.
I mean, and then that big question comes in. So symptoms, are we treating the symptoms? Are we treating, how do we clinically diagnose, and what are we going to use to as a measure to treat
again,
them?
I think it's the aim of it is the symptoms. So if someone has on biochemically, so on blood results, low testosterone, but they have no symptoms, are you going to treat them?
Yeah, no.
So you aiding
ruled out
pa-
everything else, right?
So-
So
Yes, as a
Sure.
doctor, you're gonna have to rule out
Thyroid.
other
But say they have
causes.
no symptoms. You've just a patient say
You just said,
50
"I need
years
to
old.
do my blood
You've
test."
done their blood test, and you see that he has low testosterone, but he's happy with his life.
So in a
yeah,
patient
so
like
are you
that, in a
gonna-
patient like that who's just come for a regular checkup,
Yeah.
just says, "Hey doc, I just want to get my bloods done. I'm 50 years old. I feel like everything is fine. I've got no issues." But then you do the bloods and it comes back showing low. Maybe then you probe a bit more. Hey, are you not sleeping? You may find
Or I
something.
think you can even probe before you take the blood, and then you don't even have to take the blood.
Yeah, I
in the
suppose.
first place.
There's no need,
Yeah,
yeah.
if
I
there's no
suppose.
need.
But I mean, okay, let's say we've gone through the full screening process. This guy has nothing wrong besides his test levels come back low. Are we giving him test or not?
I think the aim of it is to treat patients who have symptoms and biochemically low testosterone levels.
Okay.
So it's a
But
combination.
yeah, leaning obviously. I mean, obviously, main component has to be low testosterone, but we're treating symptoms of
Yes.
the low testosterone.
I see. But okay, let me give you another example. If we had a patient that came with just, for example, just depression. I'm feeling depressed, low mood, I can't seem to function. And then you do the test level and his test levels are normal. He's got none of the other symptoms. Are we treating him with test? Or are we referring him to a
But
psychiatrist?
his test levels are normal.
But his test levels are now at normal.
No, I think I think ideally you should explore all the other options as well, because, I mean, again, there are cons with just starting the person on testosterone. You need
Yeah.
to rule out a lot of other things as
depression
well.
Is multifactorial
Exactly.
As well, so you're not
Yeah,
just
yeah.
gonna shoot.
So
you have to,
is there,
it's per patient. Like what
Yeah.
you're talking about is usually edge cases. Most of the people we see who need these problems actually have low testosterone.
yeah.
So in those cases, I don't know. I haven't seen those kind of situations happening where there's a normal testosterone
Yeah,
and they have
normal.
symptoms
Yeah.
of low testosterone.
Yeah, they do have
Right?
symptoms.
Obviously, in those cases that you're mentioning, it's probably something else that's causing it, maybe hypothyroidism or something else.
Yeah.
Rule out everything else,
Yeah.
and with you doctor and patient must decide together what to do, and it's also personal.
I think that's a fair way to put it,
Giving
because there is a lot of
testosterone like Smarties. You get
Can I
some.
just
because of the
Can I
side
just add
effect
something?
profile.
That's
we can't.
where-
There actually is it's called an ADAM questionnaire to guide with those complicated ones, because I mean they're actually going to be rare. I mean, majority of the patients we're going to see with the symptoms are probably going to have low test.
Low test.
But if you
Okay.
do find those funny cases where it's high, but they have they have all the symptoms or whatever, there actually is an independent questionnaire you can use.
Because maybe that guy's baseline.
Exactly.
The guy's baseline.
Yeah. So the questionnaire is it's quite important. It will help you
So-
then score the patient. And it also can help you in patients who don't report it
Yeah.
at first.
I've got a question. Like another example.
Can I just cover some of the questionnaire?
Yeah, sure.
yeah,
Give
yeah,
us a
sure.
questionnaire.
Look
Why,
for-
just
yeah.
quickly go through a few of the questions that you'd ask.
Yeah.
And maybe
Yes,
people
yeah,
at
yeah,
home
yeah.
can do the
Can you just check?
questionnaires
Yeah,
screening
exactly.
for themselves.
So, for example, some of the symptoms which we have covered. So, a declined feeling of general well-being. So, just anhedonia.
These scores
right?
scored
Yeah.
1
So
to
you'll
5.
get a
1 to
point
5,
for that,
yeah.
depending on if it's moderate, if it's mild, whatever. Things like joint pain. Are they complaining of muscular aches a lot? Excessive sweating, increased need for sleep, irritability, nervousness, anxiety, physical exhaustion, decrease in muscular strength, a depressed mood, feeling that you have passed your peak, and feeling burnt out, having hit rock bottom, decrease in beard growth, decrease in ability and frequency to perform sexually, decrease in the number of morning erection, as well as decrease in a sexual desire. I mean, quite a comprehensive cover, because you can see they're covering a lot of like cognitive problems, physical problems, and sexual issues, exactly. And then you get a score out of that, and from that score, depending on whether so you'll have like you fine, or you have mild. Your mild case, your moderate case, or severe case. And then you then discuss with your patient that, listen, you do have problems, even though your test is telling you something else. But it's quite mild at the moment. Should we wait maybe a year or more?
Or even
And-
like
and-
less invasive, like
Yes.
lifestyle modifications,
yeah.
things, to naturally
So guys,
stimulate.
this is something that I want to check up on. Let's say, I mean, you guys are in the gym. Maybe this has happened to you before. Maybe it hasn't. Someone comes to you, a patient comes to us and says, listen,
the
doctor,
gym?
no, on Gents Clinic. Someone comes to you and says, Dr. Essa, I'm in the gym. I use juice. Please help me do it safely.
That's a tough one. That's a
It is
tough one.
It's a tough one.
I mean, ethically, and that's kind of the question I was getting around. Somebody who's saying,
No, I mean, I get that a lot.
Yeah, that's what I said.
Yeah.
I
So
asked
maybe
you-
you
I
can
get
tell-
that question
tell
all the
us,
time. So, I mean, the first thing I do, I mean, above everything, I'm a medical professional. So,
Yeah.
I mean, I signed a Hippocratic Oath to always do no harm, So, I know from my training that the side effects of this medication, which normally outweigh whatever they want to get. So I try my level best to first outline, because people are going to take it, whether I say it or not.
Yes.
Actually, if
They're gonna
you're
take
going to
it
start off, which is what I've learned
and
through the
also,
years.
like, I think it's important to mention that people coming up to you in the gym and asking you, that's not the correct way. You need to actually consult, which we
Yeah,
have a platform
yeah,
for,
yeah.
While you're
to
giving your
consult.
answer- while you're giving your answer, I just want to say that I'm standing on the side that we should help them, and I'll explain why. But you can.
That's fine. That's fine.
But see, again,
but,
all of these
but
drugs.
the thing is, maybe it's
Yeah.
because you cut me.
Yeah, sorry.
I then tell you what I know about TRT, or try and sort of. Normally, I'd find out, why you asking me this question. Have you taken anything, or what do you know about stuff? And I mean, 99% of the people I talk to know nothing. And I know they're taking stuff, and they'll the person will say, I see guys, they're growing, I'm not, and I mean, I've seen you in scrubs, maybe walking out the gym, you're a doctor and you fit, so I'm sure you're the best person to ask. And I mean, obviously, I'll try and sort of find out how much they know and try and sort of add any gaps, and then we normally take it from there. And in all of that, I make sure I highlight the importance of getting help, the importance of cholesterol
Checking
checks,
yourself,
prostate problems, diabetes,
Blood pressure.
sleep problems, sleep apnea is a big one as well.
So what changed
So-
my mind in all of this? I was in a conference also a few years ago. There's a non-profit organization that helps drug addicts. So basically, Nyaupe Boys gives them clean needles.
But these
clean,
guys are basically drug addicts.
Yes.
Hey,
So
I
this
mean,
non-profit-
testosterone can be an addiction.
A whole lot of drug users, heroin, Nyaupe, go to this non-profit organization, goes to areas in Soweto and hands out clean needles, clean syringes, cotton wool to clean proper tourniquets so that they can inject themselves properly. Because they also have the same thing that they're going to do it no matter. And in that, they are decreasing HIV transmission. They're decreasing things like heart problems like endocarditis. They basically, so that's the whole concept behind
The whole
it. And I
concept
think-
is to rather help a person and
Yes.
then help them do
So-
it the right
Do it
way.
relatively
Yeah.
safely.
Yeah.
So if you come to me on Gents Clinic and say, Doc, I use steroids to look good, but I'm scared of the end result of this. Please help me. I'm going to help you just like
Yeah.
Dr. Vilakazi
No, but
said,
but
yeah.
but
Or would
another-
you? I think the question he is actually posing is like, should we at the outset say, guys, never used before? Are we going to say, look, I'll help you because I know you are going to use it, or would I rather say, don't use it
I think
because
we
you don't
should-
have
I
a
think we
reason
should
to use it?
discourage it. But once they start,
Exactly.
we can help. But not to say.
What do you think,
I
Nassim?
The thing is,
support.
most patients who actually come to us have already started.
I
Have
agree,
tried
I
something
agree
in
with
the
that.
back room, yeah.
What you're saying is like a patient we've not even seen before, which doesn't actually
Mm.
happen. What's actually happening is that there's people in their 40s and 30s who actually have low T who are not getting help. Those are the that's who we're there for, right?
And,
There's
yeah.
people who have taken prolonged TRT, prolonged juicing and prolonged testosterone use, and who are now who now have hypogonadism and need our help. Those are the people we're there to help. That's actually what's happening. This is coming from the stigma of, there's people who are just coming to get juice for like TRT. It's not happening. Most people actually need help.
But what if, say, for example, someone comes to you and they give you all of these symptoms?
Yeah.
So that they can be put on TRT.
Yeah, would you give
I haven't
them
seen
with
that.
a normal level?
I haven't seen that
could.
though. Vish, I haven't seen that.
We haven't seen
and they
people-
won't even
So-
have those problems. They won't people be gymming normally. They'll be seeing
But they'll
muscle
tell
gain.
you, I've got this,
They'll
I've
be
got
doing
low
that.
mood, I've got
and
this,
if
like
they
that.
do want
Sorry,
that,
you
most
know-
likely 90% of them won't even come to us.
on
They'll
social
go
media,
to
there's this new trend now where even with normal T levels, people are claiming natural, but just constantly on TRT.
Okay, but
And it's true. Have you guys not seen on Instagram and TikTok and
Everybody's there.
and YouTube?
Everyone's natural, but
But on
they-
TRT, they're not on
Also, they're
on
going to a
gear. They're not
professional.
on gear, but they're on TRT.
On
So
TRT.
you take like superhuman or super like normal like really high levels of TRT. So you have super levels of testosterone.
but that's the thing.
But it's
We
not-
aren't going, Advish, we aren't going super physiological.
Yeah, we're not.
We're not going super physiological. So
Sure.
Yeah, so our aim, obviously, and I think the aim of most medical professionals with TRT is to keep your levels within the normal range. So higher than what it is to get you to possibly even the higher upper limit of normal, where you're not experiencing the side effects. But when the guys go and juice, they want levels. So, the range now that we use is about 300 to 600. These guys are like sitting in 900,000 levels and persistently at that level.
1,500. Yeah,
Really?
High things,
Wow.
yeah.
So that's essentially what we're looking at. But the question then comes in, are we enabling? And are we enabling or creating a worse problem, or are we helping people to do it safely? And back to the study that you or the organization that you spoke about in Cape Town, in Portugal, what they've actually done with drugs, they've legalized everything. You can get anything you want. Steroids. You can get.
I think in India as well,
Sure.
you can get steroids.
No.
No,
I know Swaziland.
but you probably can.
You probably can. I mean,
You can.
everywhere you can get steroids.
You
but
can get all these things.
in
everywhere.
Portugal, they fully legalized it, and the rationale for doing that is so they've legalized everything. So everything is available and everything. There's no taboo around it. They found that a lot of the time, these types of whether it's steroids, whether it's recreational drugs, they found that people will seek these things out because there's a little bit of a taboo. I'm doing something naughty. But when it's actually that taboo is taken off, when nobody thinks of it as something that's the secret and we can't do this, we're not supposed to. It's like bro, everybody's doing
You're
it.
jumping through hoops to get a certain thing.
Yeah. So there's one. So that's the first reason. The second reason is just like that organization, they give free needles, whatever. And what they found is when the people are coming for their needles, a lot of these people want help, but they don't know how to find it. Now, the Nyabe boy that's sitting in the street corner, he can't find help, and there's no way he's getting to a doctor that's going to help him. Now, every month he comes for a needle, and there's a doctor or a nurse. When he signs for it, they have to do a counseling session. So in that session, they say, listen, do you want to stop? We've got a center. And they've actually found that there's a decrease in number of addicts in the country because of that. So including that, over a 5-year period, they found an actual reduction because now all those previous drug users are now not sitting in a park getting high by themselves. They're coming there every month. And so every month, there's always a chance I can get better. I can improve. Okay, let me of the 10 people that come, if you're getting one that's going into rehab, you're good.
Yeah.
So I think in the same way, I think it applies in this situation. If you're getting a large proportion of people that are coming to us for help or saying, I'm going to use this thing. And you say, well, look, we can help you optimize. So we're not going to blast you with testosterone and get you in the 1,000 levels, 1,500. Let's see if we push your levels to upper limit of normal. So where you're not experiencing high symptoms. I know about this. Isn't there like you got to cycle the stuff? Right? Now, obviously, we don't really cycle
We don't
TRT.
know about the cycling, yeah. But
We don't
when
really,
you
but like when they're juicing, then they blast their levels to 1,005 cycle. So, okay, let's say, for example, a guy comes, he's done 2 months, 3 months of this. What's your
TRT.
Or not of TRT, he's been blasting, he's been hitting his levels.
So
in
what
the
I wanted
thousands.
to come on the
how
safety
are
thing.
we going to recorrect that? Like, what's the stepwise process? Because he's obviously messed up that
Yeah.
axis we spoke about. How are we going to counteract that?
Can I just mention on the safety part? Because I just think guys who are using steroids will come to us and think, yeah, I'm going to do it safe with the doctor. Yes, we can guide you on those things that we can prevent, but there are things that we don't even know you have or can't prevent. We don't know if your heart arteries are going to spasm and you get a heart attack.
Exactly.
Or if your heart, you're going to have sudden cardiac death and your heart just stops and you collapse.
Because of the hyperviscosity.
Exactly. So we don't know if your arteries are
And your lipid profile.
your
what you're
lipid profile.
predisposed to.
So we can give you medication to reduce your blood pressure, your cholesterol, but we can't stop your arteries from expanding and getting like aortic rupture, where the large vessel of your heart ruptures and you bleed out to death. So there are certain things that we just won't be able to help you with. These things are dangerous possible outcomes that you may be predisposed to. But we can help you with those things that we can control. So there's no safe
So
way.
like talking about just like realigning the hormone profile, how would you start? Like,
So
where would you
Yeah.
start?
So I mean, the best thing would obviously to make sure that the patient stops, right? So that's the first one, and assessing for withdrawal, because like any drug, there's withdrawal. So if you're gonna
So what would they generally experience if they're going through testosterone withdrawal?
I mean, like normal withdrawal. I mean, depending on like Brandon's person. I mean, that person was taking what, a gram a week. I mean, that person was superhuman, right? So whatever he was taking it for, he'll start noticing a huge dip in that. For example, let's say this guy used to, take it just to lift, I don't know, whatever, 500 kilograms of. He's gonna have problems with all of that stuff. He's gonna have problems with sleep. He's gonna have stress. He's gonna have, insomnia, like I said. So you first assess for that. Are there any withdrawal symptoms? And if there are withdrawal symptoms, then you can't just chop it. Then you have to work with them and taper it down.
The reason why the patient would have presented though is because they would have stopped the stuff and now are experiencing those side effects.
So there's ways also, we spoke about using medication that stimulates LH to make your testes produce its own testosterone again, since you're no longer putting testosterone into your buttock or into your arm. So trying to get your own body to make its own testosterone. But is there a point where your body will just shut down? You spoke about when your testicles shrink, because this patient I saw, his testicles actually had shrunk.
And even shrinking. I mean, how do we send patients for an ultrasound?
No, he will tell you. I mean, you can even feel this is not a normal size. So when you examine testes,
Yeah, but what's the normal size?
Fish,
Is
you
what
can
I'm trying
tell
to
us.
ask.
I mean, I know personally when I examine testes, I just have this, because you
There's
do it
no
all
way.
the time.
There's no way.
What you can
So you hold your own. You've held all our testes here in the same ball. It's
So
the
I
same
guess it's
thing.
like
Okay,
when
so
you-
let Vish tell us about testicular size.
Yes.
Just quickly tell us a little bit, because
Different things can affect, obviously, size, varicose, seals, previous infections.
But if the
or
guy says
cancers
to you,
or
my
tumors.
testicles have shrunken, that's
So again, it's
that's subjective.
what were they before? Has it shrunk from before till now? Or were they always like this? But again, like radiologically, I mean, clinically you could have obviously, but
I think-
radiologically on an
I mean,
ultrasound.
if a guy says to you, I've been using a gram a week for 3 years nonstop, and he says, now my testicles have shrunk, obviously as a doctor, you put the two together.
of
No,
course.
You don't need to.
Of course,
The
like-
reason,
like-
the
like
reason why I'm
raisins.
asking about this, it's because, I mean, everyone says this, your testicles will shrink.
Yeah.
But then, I mean, have you never asked yourself, yes, testicles shrink. I mean, I might think my testicles have shrunk, or you might think your
But they
testicles
don't
have shrunk.
shrink. Do
or
they
whatever.
shrink?
But
Normally, no.
Do they actually, when they shrink, do we have numbers? Do we send these patients for ultrasound?
There is volume, isn't there?
Aren't there better ways of
Ultrasound.
checking?
Yeah.
You can measure.
But I
There
think,
is those beads.
But I'm sure measuring test levels and just seeing that.
Yeah.
I mean,
So
if
again,
they've
you can have like like smaller testes or something, but normal testosterone levels, for example. So you may have someone who has like large
But if a guy
testes,
says to you,
but it's not
my
producing.
testes have halved in size. Because guys, you all know as you're sitting here, you know how big your balls are.
No, but
So if tomorrow you wake up and your balls are half the size and flakes, you're gonna know that my balls have shrunk.
Another one. So
and obviously, these are both must shrink at
So
the same time.
it's not just that.
It's not like one.
also-
What if
it's
one
also
shrinks and the other stays the
so
same?
It's not just. It's also the consistency and yeah.
that
So
changes.
if you have like large testes but they're soft, it also means that
also a problem.
there's also a problem.
Wait, but is that something that TRT may do to you? Or not TRT, but like obviously high, super.
So even other basically or like poorly functioning testicles, so like testicular failure almost. You can have patients who have other medical comorbidities, diabetes, metabolic syndrome. There are other things like HIV, TB and stuff in which scenario you may have testicular failure. So it's not just obviously volume, but also like the consistency. Yeah.
Yeah. No, I mean that's interesting. So just quickly,
You may have someone where you feel like a large testicle, but it could be hydrocele as well.
Yeah.
Oh, it's cancer, hard
You know what's interesting?
But the same guy, that's a valid point actually, because you said he's obviously been injecting so often. That's something that can actually happen. So I think it's wise that you did obviously do a scrotal examination.
See, man, I'm not just playing with patients' balls. Yeah, I'm doing proper
Guys,
things.
just one last question. So if you see a 26-year-old gent who says, "Listen, I've made up my mind. I don't want kids. Can you guys give me TRT as a preventative measure? I'm married. I can't use condoms in my marriage. So, I heard you guys in your podcast saying that DHT blocks this, LH blocked. Why can't we use this as a form of contraceptive?"
It is actually.
Does actually, yeah.
Yeah, it's happening. They're using it.
who uses that? Who wants that?
They make. Have you not heard of the
Was it
the
studies,
medical male?
It is, yeah.
Castration?
No,
Not castration.
the male. What do you call it? Male contraceptive pill.
Yeah.
Oh, is it just testosterone?
It's basically testosterone.
Yeah.
But then you're gonna have all these side effects, surely.
Yes. So,
Yeah.
Well, I mean, females on
Females on contraception also have their side effects. So I mean, hey, I wouldn't mind. I'll take my chances. I'll roll the dice.
Well, with HIV in South Africa,
So you have your normal testosterone, which
It's oral. It's just oral testosterone.
From there,
That's
from there
basically
you'll
it.
obviously produce DHT and estrogen as well.
So 25 minutes.
But the thing, look, the reason why most men come and ask us about their test levels and why they want it is because there's sexual dysfunction.
yeah.
And I think we've touched on the diabetes test and erectile dysfunction and how that all ties in. But Nas, I think you want to say a
yes. So this is
little bit about that.
This is very. We see it all the time. It's very, very common. It's an elderly man, right, with low testosterone, erectile dysfunction, and diabetes, right? There's a stigma that people say that, so you need to fix your, like I hear it all the time, like fix your diabetes and your hypertension first before you think about correcting your erectile dysfunction, right? We treat them both at the same time, okay? Treat your hypertension and diabetes and also medication for erectile dysfunction. But the underlying cause of all these things usually is low testosterone. Right? So if there's something like how you always a triad in medicine. There's a Beck's triad, the Verkaus triad. Let's make one called the NASA's triad.
NASA's triad.
It's a person who has erectile dysfunction, low testosterone, and diabetes.
Yeah, so you have that triangle.
Right.
Erectile dysfunction, diabetes.
Yeah.
Low
Low
testosterone.
testosterone can make diabetes worse.
How?
There's studies that show like it's metabolism and all of that, right? It does happen. So if you increase testosterone levels, you can improve your diabetes and your glycemic control, right? Also, it improves erectile dysfunction with increased testosterone, right? High uncontrolled diabetes causes microvascular changes, which also causes erectile dysfunction, right? And all of these, both high diabetes and low T, cause erectile dysfunction. So this is the thing we see all the time.
Publish this because some Prof van der Walt or van der Merwe is listening.
Van der Merwe's triad.
He's gonna make this triad. I'm telling you, you better capture this thing.
But it's like it's an aggressive cycle. So low testosterone causes worse metabolic abnormalities,
worse.
which is going to worsen now your diabetes as well. You have more like abdominal visceral fat as well, or like abdominal waist circumference is larger. With that higher fat, you're going to have higher estrogen levels, and it's like further decreased
So we can say TRT and insulin resistance,
Yeah.
TRT
Yeah.
and insulin
Yeah.
resistance.
which is
leading
diabetes.
Yes.
leading to erectile dysfunction. And that's why most people come to consult with us, because the one time a man will come and ask for help, because I mean, we know studies have shown men won't come and ask for help.
doesn't ask for help.
Men won't ask for help. They've got their chest pain has been going for 2 years.
Yep.
The moment they can't get it up, the moment they cannot last
The
long,
manhood is challenged.
then they come to us. And then they come to us and then they start asking like ridiculous things, you know? And I don't think that the general, like, I don't think men and people in general understand how sex works. Because guys will come and they're like, you know, I used to last 5 rounds now. No, not I used to last 5 rounds. I can never. I can't do 5 rounds.
Yeah.
I want to do 5 rounds.
Yeah.
How can you guys help me? What can you guys assist me with? So I think the mechanism of sex is important. We need to discuss what is sex? How does one person and another person get together and do this deed?
Wait, what are you asking now? How
The
do you
mechanism. No, man. Look, we know. You find
What is
in
chow?
Brendan's case, you have to write an exam, play a soccer match, go to a party, find someone, and then do the deed. But I think it's important for us to touch on what's the mechanism of sex.
I think
a man and a woman, they've gotten together, we've met in the club, they're now together, or it's your wife, preferably, and then you get together, and now what happens, Nas?
This is actually not taught at all. I don't know where you guys are supposed to learn this is how this thing happens. This is not LO or whatever. But like
No, it took us 6
supposed to be
years
for
in medical
parents.
school.
No, we
people
do it in
like
LO.
Yeah.
is it right?
Yeah, we do.
Okay, so people don't know what happens during sex. What does it mean, erectile dysfunction? What does it mean what actually happens, right? So for men, like, okay, let's start from the beginning. There's like a sort of phases that happen, right?
Okay.
So like there's that pre-arousal phase where you start to begin all this process,
Foreplay.
right? Or we call it
Foreplay,
foreplay.
yeah.
Right, so it's called
Before
foreplay.
you went
Foreplay.
together or when you're together?
When you're
with the-
together.
Oh, okay.
Right, so
No, but I mean, foreplay, you can start, hey, baby.
Yes,
tonight.
even before. Like,
Or is that
so-
not before you even
That's four
decide?
before the
foreplay
play.
is even that. Even
Yeah.
when you just
So what about
meeting.
even before that, where you tell yourself tonight I want to chow?
That's men's foreplay then.
You're telling yourself that.
Yes, that's getting yourself ready.
Self-
Yeah, but
foreplay.
that's also
all
it's the same
foreplay.
thing.
From the
Look, in your
beginning.
mind,
From
but
the
obviously,
beginning.
like even for a woman, like telling a woman, hey, this is what I want to do to you, and what's this?
Or even things
A
in
woman
your
reading a
mind.
book can be foreplay. Reading an erotic book, watching erotic movies, whatever. For
So-
women and men,
yeah.
it's very different.
Yeah.
But and it's far more on the female side. Foreplay is far more for the woman than it is for the man. A man doesn't need as much.
Yeah. So we're not building arousal, it's foreplay. Then it starts to build and build and build, right? And now we start to have intercourse, right? So this is
But
when,
wait, before you intercourse, during the foreplay, at what point should a man expect that he's going to get an erection? And what happens to the woman during foreplay?
so like it happens, isn't it like a
I think
sort of meme?
I think this is testosterone dependent as
Yeah.
well. Because when you're a kid, you have an erection when you're just thinking.
Whoa,
I want
kid.
to chow.
Whoa,
when you're
kid.
just talking
No,
to a
when you're
girl,
a
you get an
teenager,
erection.
Yes,
when you're a
yes.
teenager, you just think in your head, I'm gonna chow tonight.
Yeah.
As it
You're
when?
crying. As a teenager. Huh? But then you have men who only
Sure.
get an erection just before they're about to have actual
Yeah.
penetrative sex.
So I think it definitely varies for
Yeah.
everyone.
So it
There's
varies.
no,
It varies.
but I
There's
mean,
no
in
straight
general,
cuts.
obviously, you should get an erection during foreplay.
I mean, in our
So-
20s, and if you say to me, like, I was about to have intercourse and I was still not hard, I mean, I look at you funny, man. You know? You're in our
Like, what are you saying?
Like,
What
what
are
are
you
you
talking
saying?
about?
Exactly.
Yeah.
For example, what if you actually just were not attracted to the woman?
Yeah, I mean, that's also another thing.
Yeah.
It's never stopped you, Bri.
It's-
Has it ever stopped?
So no, guys, yes, you're getting distracted here. So yes, so there's
it's a build-up of
pre-phase.
arousal.
Like-
Yeah,
Okay.
it's a build-up of arousal, and
Build-up
at
of
some point, you
arousal.
should get an erection.
Yes.
Okay, yeah.
And that's the spectrum that happens when you get the erection, right?
Let's allow Ness to explain.
Watch this.
Okay. Not talk.
Gabby's not gonna
So-
watch this one.
I'm telling you, man. That's how I'm trying to
guys,
get to the story.
guys are clown.
Okay,
Okay, the different phases basically.
Wait, but
like
it's
look at the
important.
rates.
We need, people at home need to know. If I don't get erection at this point, is it a problem? Yes, you
Actually,
should get
yes.
in foreplay.
Yes.
You should get in erection
but
at
at
some
the
point.
beginning.
But again,
Like-
physiologically, I mean, it can be that it's normal with a certain person and not with another
Yes,
person.
so that's
So there's
But you should get in
psychosocial-
erection
there's
before the intercourse, like, because there are some guys who are like, no, I try to put it in when I'm flaccid, and I'm like, yo, man, that's not gonna work.
So think about it as building arousal, right? If you put it in before you fully arouse, then it's not going to be not a proper time to put it in, right? Or like even for a woman. So let's say like women need more foreplay. Have you heard about?
Yes, of
right?
course, yeah.
So you can't just put it in early, right? So you have to get to a certain point of arousal before you have intercourse. right?
and also just touch on why is that women need that extra foreplay.
I think they're just more emotional.
It's like business clinic. We'll get a woman to address these issues.
Let's just talk about
just
it.
Okay, fine, carry on.
So
We're just weak people.
we're building arousal, right? And we get to the point where we're sufficiently aroused enough to have a maintain an erection, and also she's wet enough or
But to
Yes, lubricated
achieve-
enough.
to
Use the
achieve-
medical
to
terms,
achieve
okay?
And maintain an erection is testosterone dependent as well. Okay, apart from vascular as well, it's also dependent on
On your test.
testosterone.
it's much
Yeah.
easier when you're younger, and then it gets worse as you get older.
Yeah.
So it just goes downhill.
Downhill. So we could get to the point of where sufficiently aroused, right? Then you have actual intercourse, right? Intercourse, you increase the arousal to a higher rate than foreplay, right? So we can talk about which are the erogenous zones, right? So let's say for a woman it would be like her breasts, her neck, her thighs, right? These are all things you must be stimulating to increase arousal, right? A lot of guys I found out don't know what is clitoris. Do you guys know what the clitoris is?
Well, before you talk about the clitoris, because it's a gentleman's clinic, where's the man's erogenous zones?
Be honest.
Again, I'm gonna say.
Be honest, lads.
think it's
Again, I'm
basically-
gonna say it's testosterone dependent. When you're in your late teens, 20s, you don't need to be touched anyway.
Yeah.
You are just ready.
Yes, of
Just
course.
exactly, yeah.
Of course, of course.
Just a thought.
As age goes and testosterone declines and life happens, and you get also tolerance to these things.
What do you mean?
What do you mean tolerance? Tolerance to sex.
To the
To a person or to sex?
Okay, I don't want to
Tolerance
open
to
another.
persons.
I don't want to open another can of worms, but
Mr. Good by himself. All right, but look, you need to.
So if things are not if things may need to be like spiced up or something,
Yeah, you
is
gotta-
that what you're just trying to
Okay,
say?
but where's
sufficient
the
to
man's
say-
erogenous zones?
Men-
Because let me
I
tell
don't-
you something. In med school, they taught us that a man's G spot is
No,
in.
no.
his-
That's a lie. That's a
we
lie.
It's
don't
not?
engage those
not.
things.
For men, it's tip of penis up to the base of penis. It's penis.
It's just penis.
There's no
And
prostate, nothing. No.
Not prostate.
Prostate is not a.
So not the
No
thing where you
pelvic
stick
floor
a finger in and
stimulation.
tickle in the front. Because that's what I've
pelvic
heard.
floor.
Okay.
But
Actually, I think if you move, you see, once you start getting perineum,
Yeah.
then
Sure.
there's something wrong now.
that's
You're starting to
traumas, no?
get stimulation beyond.
But
that
there's also
part.
like even the scrotum. The scrotum, there's also erogenous zones.
No, but guys, homosexual guys will also tell you that they do get pleasure from prostate and perineum and those.
But I think it's
areas.
also just the nerve endings around the anus.
Yeah,
Yes,
that's most
yes,
likely.
Yes,
tell
the
us,
nerve
Fish.
endings
Where's the
that I
nerve
know of,
endings? This what about like even the scrotum? The scrotum is a sensitive part.
It's the skin, basically.
Yeah.
So the same as nipple, there's also has nerve endings. The anus has nerve endings. So whether that's designed, created, developed, or evolved to be a sexual erogenous zone, we not to say. Culturally and historically, that's not an erogenous zone.
Yeah.
But people would differ.
Yeah, I think it's
At
very
this time,
subjective.
people, yeah.
It is,
really
you know,
very
yeah.
subjective.
For every man is different, but essentially it's just the genitalia
Yeah.
for us.
Effectively, right?
Okay.
For women, it's all those places.
Okay, continue. So now we're aroused, we're ready.
We arouse, and then okay, so then we get to the point of arousal, intercourse, right? And you keep building that arousal until you reach the point of the climax of orgasm, right?
What? You keep building arousal.
Wait,
But I would be-
without any,
No, just continue. Continue.
Continue,
Yeah.
continue.
Yeah.
stimulation.
With stimulation, you get to the point of climax, right? And that's when
So do all of these erogenous areas need to be stimulated, or is it one, or is it two, or is it there?
Can I
So obviously-
Does it have to be a necessary?
Yeah. So like for women, it's mostly clitoris, right, or in the vaginal, right?
Clitoris, what is that?
Yeah.
Wow.
Most of us have no idea what that thing is.
You'll be
Lots of men
surprised,
don't
100%.
No, I
No,
agree.
it's
I
true.
agree.
It is
So that's
actually
why I'm
true.
saying
Lots of men
that's
don't
important. Like as part of because we're talking about how we.
Some women actually also don't know that in the vagina there's a vagina and there's a urethra
Yes.
and a
there's a
clitoris.
You'd be surprised. Some nurses don't know how to put a catheter in those things because they don't know that there's two different things
Yeah,
that
yeah,
exist.
it's shocking. But,
So I mean, it's not. It's very common that even women don't understand the anatomy. So Nas, what is the clitoris?
So there's labia, right?
Yeah,
Those
that's
are
the lips.
the lips, right? In between the lips at
Literal
the top.
translation.
Yes.
Yeah, at the top edge, right?
Yeah.
There's going to be like a bean-shaped thing.
Yeah.
That is clitoris.
It looks like one of those boxing.
So is that what flicking the bean means?
Yeah.
Hey?
Yes. Flicking the
No,
bean.
I don't do that. No.
Not beating the meat,
okay,
flicking
so,
the bean.
so you said
Flicking the bean, yeah.
You said you reached the peak, and
They
then
say DJ.
Yeah. So okay, we mentioned how to get there, right? So there's most women actually get stimulation from the clitoris, right? So guys don't know where that is. Women never get orgasm. They don't know what they never
Yeah.
satisfied, right? So try and stimulate that as much as possible, right? And then if you
Prior
But
to.
wait, not as
no,
much
but
as
can
No,
we
this
just
is-
can we
man.
address more of the mainly? Because then we can get a woman to tell us. You know,
Yeah,
maybe
about
you
this.
need-
Sure,
we
we'll
actually
talk
need
a lot more about that.
Should
But
we-
yes,
we-
it is important.
I think we can even do a poll on our site, if the viewers want to see
Yeah,
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 you
appear
tell us
next
more,
on our
you know, we can get a
podcast.
sexologist.
Yeah, we can get a lady to come in.
But
and
there's a
talk
saying that
about
you don't ask a fisherman you don't ask the fish how to catch fish. You ask the fisherman.
What if the fishermen don't know what the fish looks like?
What if the fisherman is not actually catching fish?
Blind.
he's just that's just his title.
He's just going out to the sea.
He's just in the boat, just wandering aimlessly. But look, because with the Gents Clinic, let's talk about how what it is for a man. What does a man experience during sex? So now, is there stimulation, and it's important for us to determine this.
Yes, yeah. So
Define this because we have a lot of people consulting for erectile dysfunction, which
Yeah.
you've addressed at
Yeah.
which point you need to
Premature
get,
ejaculation.
and then premature ejaculation now.
Okay.
Reaching that arousal.
So at the point of arousal, you've now had so much time of arousal, and if you can't get an erection, that's erectile dysfunction.
Yeah.
So you don't have you're not hard enough to go in, right? Or you're not hard enough to stay in, right?
Yeah.
That's erectile dysfunction. Premature ejaculation would be that you do have a sufficient erection.
Mm-hmm.
Then once you go in, you don't last long enough to satisfy
What
her
is
or
like the
yourself.
time?
It's the time.
What?
So a few minutes.
Some people say 2-minute men, but is
Exactly.
it 2 minutes? Is it 5
No,
minutes?
so the
Is it
studies-
10?
It's
Most
5 minutes.
studies is
Less than 5
4 to 6 minutes is the average of a man, of
Like
an
a
average
normal-
man. Yes,
yeah.
4 to
From
6 minutes.
penetration till ejaculation.
Yeah, so it's called the
So that's
ejaculatory
average.
latency time.
Yeah.
So that's
Vagina.
I mean,
average.
imagine doing this for an hour.
No,
which is what some
man.
of our patients think. You can just be doing this for a whole hour. I mean, it's impossible.
But there's guys who swear
People
on
who
their
swear,
mother that
yo.
they go 45 minutes non-stop,
Hour.
1 hour,
Natural,
night,
no performance
whole night.
enhancing.
whole night. I mean,
All night
No,
long.
I'm sure at the early stages they used to because
or they use medication.
And now they've
no,
hit like
just naturally because the thing is obviously with training
Training.
or
Training.
experience. Let me say
Okay,
that.
tolerance.
the tolerance level goes up.
Right, you have better control of your orgasm,
Yes,
so you can
yes,
then
yes.
prolong the orgasm. You get to a almost close to the peak, and then you shut
you
yourself
can
down
control.
again.
Is that
Then
there's
so
a
that
word
then
called for
prolongs
it?
the time.
But that's a
called,
mental thing.
Yes,
It's called something.
It's a mental thing, though. While you're still thinking about the word, but it's a mental thing.
So it's
That and you need to involve your partner a lot in it as well. eh? That's what I teach a lot of men. Is
But,
that
but
your
before we
partner
go
must
too
be-
much into that, so now you've reached climax. We're done.
It's actually a name.
The man is done.
Yeah. So now you get to the part of refractory period, right?
Yeah.
No matter what stimulation you do at this time, you cannot get an erection again, and that's completely normal. You physically cannot have an erection. So, this period lasts it depends on your age. So it can be 30 minutes when you're younger, and it can go hours, maybe even to another day for
Testosterone dependent.
testosterone-dependent refractory period. People think that, like I've seen this happens, like patients will come and say, I last one round, right? Then I have this period where I can't get erection again. I have erectile dysfunction. That's not erectile dysfunction.
Yeah.
So it's because you're in a refractory period. And what do? You just wait. It's going to come back.
It's not TRT. You don't need TRT.
You don't
for
need
that.
did mention like nervous system,
Yeah.
sympathetic and parasympathetic.
Because there's guys also who swear that they
Yeah,
can go
swear they're
5
going
rounds.
5-6 rounds.
So if that happens,
don't believe.
it's because of, it's not like one round where they last, like some people say they last 45 or like many hours, right? It's usually not one, like all night, right? It's not usually one round. It's multiple rounds. And for a woman who can say that, oh, she had this experience, it's usually like the a woman would experience a lot of foreplay during that time, or there'll be something else happening, right? That isn't dependent on the man. So then for her, she'd experience all night, but for men, it'd be separate instances.
And it's also normal for women not to, some women just cannot reach their orgasm, or they haven't figured out what stimulation they require.
Can a man ejaculate 5-6 times a night in
can.
a 12
Potentially.
It can happen.
Potentially
Here,
with
let me
enough.
tell you how it happens. Let me tell you how it happens.
How
Let me
does
tell you
it
how it happens? Okay, you go
If you have
first
a
of all,
short refractory period as well.
but even if it's a longer, you can just wait until
Yeah.
like if
What's
it's a
coming out after round 3? There's nothing left.
it cannot come. You can deplete it. Right?
Bone marrow at that point.
Tanks are empty.
But some guys are like, I'll still keep going. I don't care as long as I can get that feeling at the end.
At some point. Man.
I don't know.
The
I
thing is,
don't
you
think
won't
so.
want to. You won't want
What
to,
do you
and she
even,
won't want to.
trying
Also.
to achieve?
That's the thing. But it
But I
can
think
happen.
the thing we need the mindset we need to change is that normal is 1 round, 2 rounds. I mean, even if it lasts till tomorrow,
Yeah.
that's normal. I mean, don't feel like less of a man if you can only go 1 round and you have to sleep for 6 hours and then you can only go another round.
There's nothing wrong with that.
There's
I
nothing
think
wrong with
obviously for a lot of the men that consult us, they have a perception of themselves 10, 20 years ago and now.
And also
And so
women-
now that things have changed drastically, they're like, oh, I
women
need to
also
get
put
back to
pressure
that.
on men as well. I mean,
Yeah, there are
a lot of
women that are
social
like, no, I want to
Yeah.
be satisfied. So if you can't make me orgasm in round 1, I want you to try by round 3 maybe. And then the guy's like, at round 3.
He's
Yeah.
been
And
struggling
then
for
he feels-
hours to try and get an
Yeah.
erection for round 1.
Yeah, and now he's struggling. To close off the conversation, let's talk about what can go wrong during sex. What can go wrong? We've talked about not being
STIs.
able- STI, that's a big one. That can be, things can go very wrong.
And,
Yeah. So what can go wrong during sex? He spoke about the stuff that can go wrong prior to, so premature ejaculation, erectile dysfunction. But what can go wrong? The one thing that I was suggesting that we talk about is, woman is on top
Oh my goodness, I can
So
already
actually,
see
yeah.
it.
and she comes down, and it doesn't. How do I put this? It doesn't go smoothly back in. So she presses down and it hits her pubic bone, basically pushes on your penis, hits your pubic bone, and you get a fractured penis.
So I've consulted someone who explained that to me.
Yeah.
But obviously, the biggest thing that made me worry about him is he says that when she went down on his penis, he heard a sound, like a snapping sound.
Like a pumping sound.
But when I examined his
Shucks.
penis, obviously he was in a lot of pain. And he says when he gets an erection, it's painful. But it wasn't deformed. It wasn't deformed even on examination. And it wasn't tender. But he said when he gets an erection, it's sore. And then subsequently, it became fine.
So maybe, I mean, it could have also maybe not been that. So penile fracture it's not actually a fracture of a bone. Well, bone.
Yeah, because
But,
commonly we think that fracture means bone.
But it's essentially a tear in your corpora cavernosum, which is the 2 rods at the top of the penis.
Okay.
The muscle, eh?
It's a sponge, basically, yeah. It's sinusoidal.
Okay.
So blood falls in
Blood
that.
full sponge.
So essentially, what Phil described, so obviously, generally, it's your partner on top comes down abnormally, and then the penis bends in an abnormal position. So it has to be an erect penis and bends, basically hits on the pubic bone of the person. Generally, I mean, you would only expect it to be on one side, because if it bends on one side. And then again,
Snap backwards, like.
so at any angle, per se.
Like a snapping
So
sound.
that is normally we would hear like a pop.
Oh, okay, like a pop, eh?
Yeah.
And funny enough, actually, when they do present to the casualty, the classical image or that you would notice is actually what is that? It's an eggplant.
Oh yeah.
Yeah.
The eggplant.
It's like very swollen,
literally
bruised.
an eggplant. The way it's shaped, the way it's swollen.
So it could have been that his was not like a complete penile fracture, maybe just a small tear that wasn't like.
So the reason why, so obviously the blood now, extravasates out of that corpora cavernosum into the subcutaneous tissue, which causes a swelling on one side wherever the fracture is, and basically causes that eggplant deformity per se.
I see.
Yeah. So the treatment is obviously surgical intervention.
Does it need to be soon, or does that develop into
As an
Peyronie's
emergency.
disease? Okay.
So if you don't, the thing is, I mean, the blood will continuously just leak out. You wouldn't be able to get an erection. So think of it as like,
So if
like
you get aroused, you just get.
so think of it as like for example, like a tear in like a balloon or something. So as the blood goes in, it just leaks out, Obviously, it could be over time, maybe if you don't have an erection, the tissues could heal with fibrosis and things like that. But again, as if you obviously go into theatre for repair, you can end up with Peyronie's.
If you hear a snapping sound during sex, go straight to the emergency.
Straight to the casualty. Now, what other things can go wrong during sex?
So I once saw a guy who said he basically presented and said to me that he's noticed that he's now developed these funny little sort of sores on his penis, and obviously, I mean, I thought it's probably a sexually transmitted infection. But then when I investigated further, I found out that this guy's had these for a long time. They've been treated before. Unfortunately, I mean, he was educated enough to tell me what they gave. So I knew they covered for a sexually transmitted infection. But he still had them. Yeah, he was like, they don't change size. They're just there. And I don't know what's going on. Are these warts? I mean, can that be something you get post-coital?
What are these things?
It's like these... I mean, there's a term for it. What's the term?
What was
like
that,
small
Nas?
Pimples.
Papules.
Papules.
Penile
Papules.
papules.
Penile
Pearly
papules.
penile papules.
Pearly penile papules.
Pearly penile papules. Where do you find them? On the head.
On the head of on the glands on the edge.
Pearly penile
Penile
papules.
Yes.
Yeah,
Those
we'll
are
put an
normal.
image up
Yes,
here.
yeah,
Pearly
yeah.
penile papules.
Those are normal.
Yeah.
And those are just
They're
normal.
normal. They're not
Yeah.
actually
Can you just something
sexual.
off note as well that you mentioned post-coital or obviously during intercourse? Things that can obviously happen acutely or at the time can be a tear in the frenulum or tear in the foreskin.
Yeah.
So
You
if,
tear your foreskin.
so
These are obviously for
Frenulum.
our
Frenulum.
uncircumcised brothers
Yes,
out
which
there.
we don't know about.
We don't know these
those,
problems.
bro.
Yeah, but tell us.
so yeah, I mean, I have seen people who, they give you the history and this is what happened. And, if things were too rough or, if they have a tight foreskin per se, and, at another situation, they may, they can be at risk for phimosis or paraphimosis as well. And if the foreskin gets retracted back very traumatically, it can cause a tear. Generally at the frenulum, which is basically at the ventral aspect, so at the bottom part.
So it's the attachment of the foreskin to the glands. Yeah.
At the urethra side.
Yeah, on that note.
Yeah, on that note, I think we've covered enough on what can go wrong and what can go right during sex. We've touched on low testosterone. We've touched on juicing and how we can help you do it in a more safer manner without you damaging yourself irreparably. We've shared some of our own experiences. And that's what we like to do here at the Gents Clinic podcast. So thank you for joining us for another episode of the Gents Clinic podcast. I'm Dr. Sohail Essa.
Dr. Brendan Matthews signing out.
Dr. Naseem Sharif.
Dr. Nhlanhla Vilakazi.
Dr. Vishen Naidu.
And that's been our episode. Thank you for joining us for another episode of the Gents Clinic podcast. See you guys next week.